So picture this. You've just spent, I don't know, weeks, maybe even months, recovering from a really delicate pelvic floor surgery.
Right, and it is a tough recovery.
Oh, absolutely. But, you followed all the post-op instructions, you finally feel great, and you are so ready to get back to the gym.
You're cleared for exercise.
Exactly. So you step up to the rack, you unrack the bar for a heavy squat, you take a deep breath, hold it to brace your core, and you just push.
And right there, that's the moment of maximum risk.
Yeah. Because in that one single second of intense intra-abdominal pressure, you literally risk undoing the entire surgical repair.
It's a really critical intersection of human anatomy, honestly.
Which is exactly the highly specific mission of our deep dive today. We're talking directly to you about your body and, well, your longevity.
Because you're dealing with an environment that has been completely altered. I mean, by both the surgical intervention and, of course, the hormonal shifts of menopause.
Right. And you just want to know, flat out, can you safely perform high-resistance pelvic floor physical therapy and, general strength training?
It's a huge question.
Yeah.
Nobody wants to experience a secondary prolapse just because they, miscalculated their biomechanics during a workout.
No, the fear is incredibly valid. I mean, the stakes here are so deeply personal. This is really about reclaiming your bodily confidence.
You want to stay strong.
Yeah, you need to maintain your bone density, and you want to be an active participant in your life.
Yeah.
But obviously you are rightfully cautious about ending up back on the operating table.
Which is why sitting on the couch is genuinely one of the worst strategies you could adopt for your long-term pelvic health. Muscle atrophy is kind of the enemy of structural support.
So to get you the definitive answers today, we pulled from a massive stack of sources. We've got medical journals, clinical trial data on pelvic organ prolapse, which is often just called POP in the literature,
Right.
plus physical therapy guides, and a lot of extensive research into menopausal tissue changes.
And I think it's important to frame this not as like a list of medical restrictions that keep you sidelined, right?
Exactly. This is an empowering exploration of your own biomechanics. Because if you understand how the machine works, you can operate it safely.
At a very high level, too.
Yeah.
But to safely engage in that resistance training, we really first have to map out the biological landscape you're actually lifting in.
Right. The new rules of your pelvic floor.
Yeah, because menopause and past surgery have totally rewritten the architectural rules down there.
So let's start with the chemical environment, because we usually think of menopause as, hot flashes and mood shifts.
Sure, the classic symptoms.
But the literature shows it changes the actual physical fabric of the body. Like the
Yeah.
estrogen receptors are a major player here, right?
Oh, absolutely. They aren't just isolated to the reproductive organs. They are densely located all over the bladder, the urethra, and the muscles and fascia of the pelvic floor itself.
Wow.
Yeah, you can basically think of estrogen as the biological foreman regulating collagen synthesis in your pelvis.
Okay, so it's building the scaffolding.
Exactly. Collagen provides the tensile strength and the structural integrity of all those internal tissues. So when menopause hits and circulating estrogen levels drop,
The foreman just walks off the job site.
that is exactly it. And without that constant regulation, the tissues physically thin out, the striated muscle fibers lose mass, and those supportive ligaments, the ones holding your pelvic organs in place, they lose their youthful elasticity.
Which means the structural integrity is compromised entirely just by the passage of time and hormonal shifts.
Right, regardless of how fit you are.
The statistics in the sources really highlight how universal this is, too. I mean, about 50% of postmenopausal women develop some degree of anterior vaginal wall weakening.
Which leads to bladder issues, like a cystocele.
Right. And then another 25% face posterior wall problems, which impacts bowel function. So that's your rectocele.
And for you, the listener, you've already crossed that threshold. The weakening happened, the prolapse occurred, and you underwent the surgery to repair it.
But the medical literature makes a very stark point about that surgical intervention. The repaired tissue is permanently altered.
Yes. It doesn't matter if your surgeon did a native tissue repair, where they, meticulously stitch your own fascia and ligaments back together.
Or if they used a synthetic mesh implant to reinforce it.
Right. Either way, those repaired tissues never regain 100% of the tensile strength of virgin, uninjured tissue.
Because scar tissue and repaired fascia are just inherently less pliable, right?
Exactly. They are more vulnerable to shear stress.
So if we try to visualize this post-surgical menopausal pelvic floor, it's kind of like a hammock that's been expertly stitched up after a major tear.
I like that analogy.
Right. Like it's fully functional, it holds you securely, But now it's hanging between two trees that are gradually moving a little closer together as you age.
Because of the tissue changes.
Exactly. And the fabric itself is weathering in the sun because of that drop in estrogen. So it absolutely works, but it requires a very different maintenance protocol than a brand new hammock.
And the clinical data backs up that vulnerability in a pretty sobering way, honestly. Around 12% of women aged 65 and older will actually undergo another prolapse repair within 5 years of their initial surgery.
Wow. 12% facing a reoperation in just 5 years. That's a massive number.
It really is.
So, if the biological landscape is that fragile, we have to look closely at how the physics of lifting weights interacts with that stitched up hammock.
Right, we have to look at the mechanics.
Because we hear the word prolapse and naturally think of it as a bottom-up failure. We just assume the pelvic floor grew weak and gave way.
But the physical therapy guides stress that prolapse is actually a top-down pressure problem.
And that's the fundamental paradigm shift here.
Completely. Every single time you lift a heavy barbell or jump onto a plyometric box or even strain to move a piece of furniture, you generate intra-abdominal pressure, or IAP.
So your core is basically a pressurized system.
Exactly.
Let's use the analogy of a sealed canister for this because I think it perfectly illustrates the biomechanics. So if we imagine your core as a cylinder, the top of the canister is your diaphragm, your primary breathing muscle. The front and sides are wrapped by your abs. The back is your spinal muscles.
And the bottom of this sealed canister is the pelvic floor.
Right, so when you engage in heavy exertion, especially if you brace your core super tightly, you're essentially squeezing the walls of that canister.
And fluid and air dynamics dictate that pressure within a sealed system. It has to go somewhere.
It travels outward.
Right, in all directions.
Yeah.
And it will inevitably find the weakest point of the canister to escape.
Which, in the context of a post-surgical pelvic floor, is the bottom of the canister. The pressure drives directly downward against the surgical repair.
Yes, and the absolute worst-case scenario for spiking that pressure is the Valsalva maneuver.
Oh, man. This is such a staple in powerlifting and heavy gym culture. It's when you take a massive breath, hold it in, and bear down hard to stabilize your spine while you push a maximal weight.
Which turns your core into a literal hydraulic press aiming downward. Holding your breath and bearing down creates a catastrophic spike in intra-abdominal pressure.
Okay, but I have to push back a little on the underlying logic of gym training here.
Okay, go for it.
Because the entire philosophy of resistance training is that subjecting the body to physical stress forces it to adapt and grow stronger.
Oh, right. Progressive overload.
So if the goal is to build a robust body to carry you through menopause, shouldn't lifting heavy weights force the pelvic floor to fortify itself? Like, why does the pelvic floor even care if my biceps or quads are doing the heavy lifting?
That's a really common question.
I mean, if I'm doing a seated bicep curl, my legs and my pelvic floor aren't the primary movers, so why is the hammock taking a hit?
Because of that sealed canister effect.
Hmm.
Even if you're doing a seated bicep curl, if the weight is heavy enough that you instinctively hold your breath and brace your abdominal wall to stabilize your torso.
You're still indiscriminately compressing the canister.
Exactly. Your biceps are doing the mechanical pulling, but your core is managing the internal stabilization. The intra-abdominal pressure doesn't distinguish between a squat and a bicep curl.
It just pushes down.
If the pressure spikes, it pushes down on the repair. Period.
So the top-down pressure is just an inescapable reality of lifting, which leads us to the next big question. Does the literature suggest that high-resistance training is completely off the table?
Right.
Like, do we have to tell you, the listener, that you can never lift anything heavy again?
The sources are nuanced, but the consensus is actually really clear. No, you do not have to stop resistance training.
Oh, thank goodness.
But, and this is a big, but the definition of high resistance has to radically change. Heavy weightlifting that requires straining, breath holding, and maximal core bracing should be permanently retired.
So those days of pushing to your absolute one-rep max where your face turns red, your veins pop, and you just grind through a lift.
Those are over, yes.
Which is a massive psychological hurdle, honestly, especially for anyone who has spent years in the gym. We are so conditioned to associate progress with lifting the heaviest possible weight.
It's true. Dropping the ego and walking away from the heavy rack is mentally really tough.
But the shift has to be toward functional lifting. You swap the extreme weight for lighter weights with higher repetitions.
Because you can still reach muscular fatigue. You can still stimulate bone density and muscle hypertrophy.
But you achieve it through volume, rather than a single massive spike in intra-abdominal pressure.
Exactly. The execution of basically how you manage that internal pressure becomes infinitely more important than the number stamped on the dumbbell.
And the central pillar of managing that pressure is breathing mechanics, because the diaphragm and the pelvic floor are mechanically linked. They move in tandem.
They do. When you inhale, your diaphragm contracts and moves downward to pull air in. And in a healthy system, the pelvic floor naturally relaxes and moves downward too, to accommodate that shift.
And then when you exhale,
The diaphragm relaxes and moves upward, pushing air out, and the pelvic floor naturally recoils and lifts back up.
so knowing that synchrony, the physical therapy guides heavily emphasize exhaling on the exertion phase of any exercise.
Always.
If you're doing a modified squat, the very moment you begin to push out of the bottom of the squat, you forcefully exhale,
You are blowing the air out of the canister.
which lifts the diaphragm up and literally pulls the pelvic floor and your surgical repair up and out of the danger zone.
You must exhale on the exertion. You never, ever bear down.
Right. The literature also brings up a specific mechanical defense strategy called the knack,
Yes, the knack.
which I know sounds like a 1970s rock band, but the clinical definition is actually fascinating.
It's incredibly effective.
It's the conscious, purposeful contraction of the pelvic floor muscles immediately prior to any event that increases intra-abdominal pressure.
Right. So whether it's a heavy lift or even just a sudden sneeze or a cough, employing the knack means you are actively engaging the musculature of the hammock before the heavy truck drives over it.
You're creating a rigid, supportive floor that prevents the sudden downward descent of the pelvic organs.
Exactly.
Okay, so managing external loads like dumbbells requires constant vigilance with your breathing. But the sources also bring up a seemingly contradictory concept: internal high-resistance training.
Yeah. This surprises people
Because if we're trying to avoid heavy weights that cause strain, why do the clinical guides highly recommend things like Kegel weights and vaginal cones?
because it comes down to isolating the target musculature without engaging the entire abdominal canister.
Ah, I see.
Once a patient is fully healed from surgery and cleared by a pelvic floor physical therapist, internal weights provide progressive, high-resistance training specifically for the pelvic floor.
So you're applying the principles of strength training directly to the hammock.
Yes. Inserting a weighted cone means the pelvic floor muscles have to actively contract to hold it in place against gravity.
It's the exact same principle as picking up a heavier dumbbell for your bicep. But because the resistance is internalized, you aren't forced to brace your abs or hold your breath to manage it.
Right. You build targeted strength safely. It forces the neuromuscular system to rebuild coordination and endurance.
It's kind of like playing a finely tuned instrument rather than just banging a drum. You need precise coordination, not just raw force.
That's a great way to put it. But even with internal weights or modified external lifting, your body actually provides a highly specific biological warning system.
Right, to tell you when the mechanical load is just too high, which is the critical feedback loop.
You have to listen to it.
Because if you're in the gym doing your higher rep sets, exhaling perfectly on the exertion, how do you actually know if you've crossed the line from a good, tough workout into the danger zone?
You look for very specific physical cues. The literature points to any feeling of deep pelvic heaviness, a dragging pressure, or a physical sensation of bulging in the vagina that doesn't quickly resolve with rest.
And those sensations are not indicators of a good muscle pump.
No, absolutely not. They are indicators that the top-down pressure has overwhelmed the structural support of the repair.
So if you feel that dragging sensation, you have crossed the line, you stop the exercise immediately, and you modify.
And the exact same applies to urinary leakage during a workout.
Yeah, because we often normalize a little leakage during exercise, especially in menopause. But from a biomechanical standpoint, stress incontinence during a lift is a literal mechanical failure of the sealed canister.
The pressure exceeded the resistive capacity of the urethra and the pelvic floor. So if leakage occurs, the intra-abdominal pressure is too high, and the external load has to be reduced.
Okay, so mastering the breath, utilizing the neck, modifying the external weights, and using internal resistance cones, these are your acute mechanical strategies for navigating a single workout.
Right, the gym protocol.
But ensuring that surgical repair stays intact for decades through menopause requires looking beyond the gym, because surgery is a mechanical reset, not a permanent cure.
You have to manage the baseline environment 24/7. And the #1 lifelong maintenance strategy highlighted in the literature is weight management.
Because we're dealing with a top-down pressure system. So every single extra pound of visceral weight carried around the midsection compounds the baseline intra-abdominal pressure.
It's a constant, unyielding mechanical load on the pelvic floor. In fact, the clinical data strongly correlates significant weight gain post-surgery with a dramatically increased risk of the prolapse recurring.
It's just basic physics. More mass pressing down on the canister equals a higher likelihood of the bottom giving way.
Exactly. But it isn't just about reducing the load. It's about consistently reinforcing the support structure.
And the data on supervised, specialized physical therapy is incredibly compelling here.
It really is.
Studies show that a strict regimen of consistent pelvic floor exercises, specifically protocols demanding 10 sets of squeeze and lifts, performed 3 times a day for 3 consecutive months, resolves or significantly improves prolapse symptoms in 74% of cases.
74% is a massive clinical success rate for a non-surgical intervention. It proves that targeted, consistent muscular hypertrophy can offset the weakened fascia.
Okay, so if physical therapy provides the mechanical reinforcement, we also have to look at the chemical reinforcement. We established earlier that the loss of estrogen is the primary culprit behind the thinning tissues.
Right.
So naturally, the medical community assumed that replacing that estrogen locally around the time of surgery would reinforce the physical repair. And the sources highlight a major clinical trial by Dr. David Rahn at UT Southwestern that tried to prove exactly this.
And the biological logic behind Dr. Rahn's trial was incredibly sound. The assumption was that prescribing a topical vaginal estrogen cream for several weeks before the surgery and continuing it afterward would basically put the hormonal foreman back on the job site.
Right. The estrogen would stimulate collagen production, thicken the vaginal walls, and allow the surgical stitches to anchor into stronger tissue.
Which would theoretically prevent the anatomy from dropping again.
So they set up this rigorous, randomized, double-blind, placebo-controlled trial. Half the women used the real estrogen cream and half used a placebo. And they tracked them for 12 months to see whose anatomical repair held up best.
But the results completely upended the medical assumption.
Yeah. At the 12-month mark, the rate of anatomical failure, meaning the prolapse physically dropped down again to a measurable degree, was statistically identical.
Whether the patient used the estrogen cream or the placebo, the topical estrogen did absolutely nothing to reinforce the mechanical structural integrity of the surgical repair against gravity and IAP.
Which raises the immediate question for anyone reading this: is vaginal estrogen completely useless for a post-surgical menopausal patient?
No, not at all.
Like, if it doesn't stop the hammock from sagging, why do doctors still highly recommend it?
Because we have to separate the mechanics from the environment. To use an analogy, applying the estrogen cream is kind of like oiling the gears of an aging machine. The oil doesn't change the structural metal of the gears. It won't fix a broken tooth or realign a bent shaft, but it drastically improves how the entire system functions by reducing friction and heat.
And the secondary endpoints of Dr. Rahn's study were where the estrogen really proved its worth.
Exactly.
While it didn't prevent anatomical failure, the estrogen cream drastically improved the overall quality of the vaginal tissue. It significantly decreased the rate of surgical site infections, it prevented recurrent UTIs,
It is huge.
and it effectively reversed the painful, burning symptoms of menopausal vaginal atrophy.
So it creates a significantly healthier, more resilient biological environment, even if it cannot mechanically hold the organs in place.
I want to look at this from the perspective of the listener right now, because if I am in their shoes, I am looking at a pretty daunting checklist.
It is a lot.
I have to manage my visceral weight perfectly for the rest of my life. I have to commit to 10 sets of Kegels 3 times a day. I have to completely overhaul my psychological approach to lifting weights in the gym.
And monitor every single breath you take during a squat.
Right, ensuring I exhale on exertion. And even if I execute all of that flawlessly, that UT Southwestern study suggests that over the years, the anatomical repair still has a high likelihood of physically failing and shifting downward anyway.
It is an immense amount of lifelong daily work to ask of a patient, especially when the anatomical success rates naturally decline over time.
So is it genuinely worth all this effort if the hammock is likely going to stretch out again regardless?
The clinical literature offers a really profound reassurance here, actually. But it requires a shift in how we define medical success.
How so?
Well, yes, if you look at an MRI or conduct a physical exam 5 or 10 years post-surgery, the anatomy may not be perfectly locked in its original high surgical position. The fascia stretches, the organs might sit a few millimeters lower,
Okay.
but, and this is the most critical takeaway, Those who maintain their strength training, who utilize internal resistance weights, and who expertly manage their intra-abdominal pressure during exercise often remain completely symptom-free.
Oh, wow. So they don't experience the dragging heaviness, the stress incontinence, or the pelvic pain, even if the organ has technically shifted.
Exactly. The medical community is increasingly focused on treating the human being, not the imaging scam.
That makes total sense.
If a patient feels strong, if they are confident in the gym, and they have no disruptive symptoms, that is a complete functional success, regardless of a minor anatomical shift.
Because you're building a muscular and behavioral system around the surgical repair that is so robust, it compensates for the inevitable aging of the connective tissue.
Exactly.
It takes the immense pressure off achieving permanent anatomical perfection and puts the focus squarely on functional active living.
Which is what really matters.
So let's synthesize all of this into a clear, actionable path forward for you, the listener. The direct, definitive answer to your specific question is yes, you absolutely can and should perform resistance training.
But you must drop the ego of the maximal heavy lift.
The strategy is clear. Substitute extreme external loads for lighter weights and higher repetitions.
You must master the synchrony of your diaphragm and pelvic floor, consciously exhaling on the exertion phase of every single movement.
Never hold your breath or utilize the Valsalva maneuver. You integrate the knack to defend against sudden pressure spikes, and you embrace targeted internal resistance, utilizing tools like Kegel weights or vaginal cones.
Under the strict guidance of a pelvic floor physical therapist, of course.
Always. By adopting these highly specific biomechanical modifications, you are not restricting your life or wrapping yourself in bubble wrap. You are actively, intelligently protecting the massive investment you made in your surgical repair.
While ensuring you remain strong, vital, and active through the landscape of menopause.
Because you hold the ultimate power over your biomechanics.
It's simply a matter of working with the profound intelligence of your altered biology, rather than fighting blindly against it.
Which leaves us with a final, lingering question to ponder as you head back into the gym. We are surrounded by a modern fitness culture that aggressively glorifies pushing the human body to absolute failure.
It's everywhere.
We are bombarded with messaging to grind harder, to hold our breath, to brace our cores, and push for that ultimate vein-popping heavy lift at all costs. How does that pervasive cultural messaging directly conflict with the deep internal biological intelligence of our own anatomy?
We celebrate the external display of raw strain, while completely ignoring the silent internal cost being paid by our structural foundation.
Next time you step up to the weights, ask yourself if you are lifting for your ego or lifting for your longevity. Thanks for taking this deep dive with us. Take care of your foundation, and we'll see you next time.